Glad you could join us. My name is Billy Carson. I'm with University Conference Services. Before we get started, I'd like to give you some general information about this afternoon's presentation. First, we have a large audience, so we won't be able to open the phone lines for your questions. Instead, you can type them in the questions pane, which is on the right side of your control panel. All questions are private. They aren't visible to other audience members, so please feel free to ask away. Next, if you're listening to the broadcast over your computer and you're having difficulty hearing, dial into the phone number listed in the audio pane in your control panel. Again, that's on the right-hand side of your screen. We'll also send that number out via chat. All attendees will receive a link to the recording of today's presentation, as well as a link to download a special white paper on today's topic. You'll also receive information on HRCI recertification credits, since I know many of you are interested in that. Today's presentation is titled Medicare Part D Retiree Drug Subsidy versus Employer Group Waiver Plan. Is now the time to switch. Transamerica Affinity has arranged for an expert who's delved very deeply into this subject to speak to us this afternoon. Troy Philippek is a principal and consulting actuary with Milliman. He's been with the firm for 11 years. His areas of expertise include managed care, Medicare Advantage, and prescription drugs. He supports clients with pricing, reserving, and other analysis for medical and prescription drug benefit plans in both the commercial and the Medicare markets. He's also worked with pharmaceutical companies and industry trade groups on issues related to prescription drugs. Within the Medicare market, Troy has worked extensively with carriers and employers, focusing in particular on the Medicare prescription drug benefit. He's a key contributor to Milliman's Part D research efforts and has written numerous articles for the Society of Actuaries, Milliman, and for other publications. Troy is a member of the American Academy of Actuaries, where he serves on a number of committees, including the Medicare Steering Committee, the Defined Contribution Health Plans Work Group, the Part D Lessons Learned Work Group, the Part D RBC Work Group, and the Part D Accounting Work Group. He's also a fellow of the Society of Actuaries and of the Conference of Consulting Actuaries. Troy earned his BBA with a double major in Actuarial Science and Risk Management and Insurance from the University of Wisconsin-Madison. So you see, we have a very well-qualified expert to help us with this issue. And now, Troy, I'm going to turn things over to you. You'll have controls here in just a second. And if you will show your desktop now, you should be able to. There you go.
All right. Thanks for the warm introduction there. And thanks for everybody for taking the time out of their busy days to join the call. So today I'm going to talk about a pretty hot topic in the retiree pharmacy space today, EGWPS. Kind of talk about what's new there and what's changing in the evolving marketplace. So as far as the agenda goes, I'll just give a quick overview of the different options that are available to retiree plans. I'll talk a little bit about some recent regulatory guidance that has shook up the market quite a bit. I'll go into some of the future considerations and thoughts on where things might be headed. And feel free to submit questions and comments and input throughout. They'll assemble that, and I will certainly leave plenty of time at the end to take questions and respond to them. And if I can't get to all of them, there'll be a chance where I can follow up via email on anything that doesn't get answered. So I already went through a little bit of my background, but just more specific to this space, I do a lot of work in the individual and employer Part D markets. I also work some in the commercial space, work with PBMs, health plans, and other carriers, and employers. For employers, I've done a lot of work with plans as far as retiree drug subsidy attestations, creditable coverage testing, and helping them think through what some of these other options are with EGWPS, secondary wrap plans, and that sort of thing. And I do quite a bit of work within Milliman in terms of research and client outreach in the Part D space. As far as the focus of today, we're going to focus really on three main options, and the last two kind of go hand in hand. The first is the retiree drug subsidy. That's going to be more of a talk through of what plans have done historically, since that's been the most common option, and then we'll talk about EGWP employer group waiver plans, and oftentimes they're paired together with secondary wrap plans, and that'll kind of be most of the talk for today. There are some other structures under Part D or for retiree pharmacy coverage that are a little bit less common that I'll just touch on briefly here. So there's some employers that go directly to CMS and kind of sponsor their own EGWP. So rather than going through a carrier, they do it themselves. There's probably less than 10 of those around the country. They're called direct contract 800 series plans or direct contract EGWPs. You're also seeing a fair amount of movement these days with employers exiting the market and either group enrolling their members in the individual plans or dropping coverage altogether and just subsidizing and allowing their members to go out and sign up for individual coverage. Again, not as common as the first few options, but something that employers are looking into, especially ones that are going more towards the defined contribution type of approach. So when Part D was passed in 2006, initially the retiree drug subsidy was the most common option. The majority of employers went that route. It was kind of a status quo where it didn't require a lot of change to what they were doing today. They were able to get a subsidy from the government that was initially tax-free. Now it's going to become taxable revenue starting in this year, 2013. On average, it probably cover anywhere from 20 to 25% of your pharmacy costs, depending on what your retiree profile looked like. Since then, we've seen EGWP starting to pick up steam, especially with some of the recent Affordable Care Act provisions. So what happens under these EGWPs is an employer effectively contracts with a organization that has a contract with CMS under the Part D program, and it can be a pharmacy-only plan, so a PDP, prescription drug plan, or it can be a combined medical and drug plan, or a Medicare Advantage prescription drug plan. The way it works is that intermediary receives the subsidies from the government or from the pharmaceutical companies, and effectively they either pass that back through premium reductions in a fully insured type of situation, or they reduce the claims payments that would otherwise be owed in a self-funded type of situation. One thing that's unique about EGWPs, and this has gone all the way back to 2006, that has been beneficial for government sponsors, is the GASB provisions have favorable treatment of EGWP plans over retiree drug subsidy plans, in that when you get the retiree drug subsidy, they're only allowing you to take credit for 1 year of that subsidy when you do your long-term valuations. And so as you're projecting out drug costs, you're only able to take 1 year of the retiree drug subsidy as offset, the current year that you're actually qualifying. Whereas under an EGWP, because those subsidies are built into the premiums or as claim reductions, in effect you get to take credit for the EGWP subsidies in perpetuity for the entire length of the valuation. And so there is some advantages there that have been going all the way back pre-ACA for government entities. In general, the government tried to design the subsidies such that they were about roughly equal. What we saw is that in general, the tax benefit for private employers made a lot of them go the RDS route, and that kind of tipped the scales in their direction. And all else equal, with the subsidies about the same for non-taxable entities, a lot of them just didn't want to make the change based on being tied into union contracts or other things initially. That's all changing now with a lot of the ACA provisions. The scales are really being tipped towards going the EGWP option, at least from a financial perspective, and we'll talk about that quite a bit as we move along. So a little bit of background. This might be very basic for some, but this is the Part D benefit from 2010. This is the design before the Affordable Care Act was passed. Much different than any commercial designs, and in effect that was for government budgeting purposes, that they wanted to keep the price tag down on the bill to make it more likely to get passed. So they wanted to kind of achieve two real goals with the benefit. First is they wanted to have some benefit for everybody, really, so that anybody buying into the program would get some relief on their prescription drug costs. And that's where you see the plan coinsurance between about $300 and about $3,000. So most beneficiaries benefit from that, and you know, they pay a premium for it, but that's where a lot of those premium dollars are going for the average person. Then they wanted to provide extra support for both high utilizers and for low-income beneficiaries. And so from the high utilizer perspective, there's this big government reinsurance bucket once you get over a certain out-of-pocket spend amount. That's $4,500 in 2010. It's indexed every year. Once you spend that out of pocket, the government comes in and pays 80%. The plan pays about 15%. And so the remaining part, the member only pays about 5%. So there's quite a bit of relief once you get out to those very high spend levels. And then for low-income people, their benefit throughout is subsidized, so they pay very low nominal copays. It varies depending on how low income you are or what FPL status you have, but it tends to be much reduced relative to what the average non-low-income beneficiary would see. So, and just to walk through this a little bit, there's a deductible up front that's about $300. Then that plan coinsurance where the member pays 25% from $300 to $3,000. You get to the donut hole or the coverage gap from about $3,000 to about $6,500 in total spend, or about the point where the member spent $4,500 in spend, and then the reinsurance kicks in. So that's just a picture of how things looked pre-ACA. So then ACA comes along, gets passed in 2011. There was some discussion about Part D, but it in general was not the focus of the conversation by any means. In general, it's been a very well-received program by seniors that are enrolled in it, and those are the folks that tend to vote in masses. And so it hasn't been an area that there's been a lot of political disagreement going back. It's been more small items within the program and not fundamental changes. And that's what came along with ACA. I think in general this is one of the few government programs out there that has come in under budget, and it's been fairly substantially under budget. I don't recall the numbers offhand, but I think it's in the upwards of 30% or so relative to the original projections from the CBO. Two main drivers of that. The biggest one is the generic pipeline. There's just been a substantial number of generic drugs in the last 5 years that have really mitigated drug trends and helped keep costs down. The second thing is an extremely competitive marketplace. I think the government is kind of looking towards Part D as they roll out the Affordable Care Act exchanges and state marketplaces, in that Part D is extremely competitive. There's a lot of carriers in the program. It's very price sensitive. It gives members the opportunity to really see how plans provide coverage relative to their drugs in their area, using their pharmacies. So it's very transparent to the member and allows them to select the plan that's best for them, and that leads to a lot of jockeying and competition among the carriers in the program to try to appear or be the most attractive plan out there. So again, I'll go through the change coming up on reform, but it's generally tinkering around the edges. I wouldn't say these are a substantial impact like it is to some other markets, but if you're in this space, it certainly is you know, a fairly big change. The biggest change under ACA is the manufacturer coverage gap discount program. It's where the pharmaceutical companies, as part of the negotiations that President Obama had with all these different stakeholders as part of ACA, the pharma companies agreed to pay 50% of brand ingredient costs in the coverage gap for non-low-income members. So a couple nuances there. It's brand-only medications, so that can create, in some cases, some reverse incentives from what you usually want in terms of having generics generally always being a preferred option. In some cases, brands can actually be lower cost to members in the coverage gap based on that subsidy. The other thing to keep in mind, this is only non-low-income people. Low-income people, because their benefit is already subsidized fairly substantially, they didn't need to have the government or the pharmaceutical companies come in and kind of replace the government from subsidizing that piece of it. The rest of the coverage is going to be covered by either the government through their subsidies or the member. So in addition to that 50%, on brands, generics are going to be scaled all the way down from 100% member cost sharing to 25% member cost sharing in the coverage gap by 2020. And then on the brand side, the plan is going to come and pay down from 70, kind of pay down from where they are today, 100% down to 75%, and then the remaining 50% is paid by the pharma companies, such that in the end the member would have 25% cost sharing before the coverage gap that we have today, and then in 2020, once they're in the coverage gap, the benefit would be the same. The other change on the RDS side, as I mentioned earlier, the tax deduction or the tax status of that revenue stream from the government changed, such that now those amounts that are received are subject to government federal income tax. This was the first provision that really took effect out of all the Affordable Care Act provisions, based on accounting rules for private organizations and government entities for that matter too. You had to reflect this impact immediately once the bill was passed. So March 23rd, 2010, the next quarter of reporting, all these organizations had to come out and make very large adjustments to their post-retiree liabilities based on the fact that they were going to have to pay tax on those amounts now. So you saw AT&T and Verizon and very large retiree populations having like $1 billion hits on their post-retirement liability just based on this tax change. So it was a big hit, and it hit immediately in 2010. So as far as the coverage gaps reforms, historically this has been a controversial item. As I talked about earlier, it's kind of a budget purpose. The reason why they had this coverage gap is to keep kind of the price tag down. But there was issues where members had very high cost sharing in the gap and were becoming non-adherent to their medications in some situations, which isn't what anybody really wants. So that's where pharma came in and pledged this amount. Interestingly enough, if anyone has seen or reviewed the president's budget for 2014, he has followed that he wants that percentage to go up to 75% on brand drugs. So effectively taking away what the government or the member would be paying and putting more on pharmaceutical companies to cover not just 50%, but now 75%. I suspect that's not what the pharmaceutical companies thought they were signing up for, is an increasing share of the pie, but that's where it is. One of the important things about this pharma discount is that it counts like it's member cost sharing. So it doesn't delay the point at which the member would get to catastrophic reinsurance. It gets them there on the same schedule as if they were paying it out of pocket themselves. So no delay there, gets them there at the same time. And then RDS plans are not eligible for the pharma discounts. It's a Part D only benefit, and RDS plans are not technically Part D. So this shows the Part D benefit in 2013, the current year. As you can see, no change in the far two left corridors or the right corridor. It's all in the center where the members portion has gone down. That beneficiary corridor has gotten smushed a little bit, and the pharma discount has taken the lion's share of it, and the plan through government or member funding has covered the other portion. And this just shows a numeric view of it. So you can see the generic coinsurance scales down 7% a year and then 12% in the last year. The brand coinsurance starts with a slow amount. It's only down where the member's paying 97.5% now, or before the pharma discount. So the plan's only paying 2.5% right now. pharma pays 50, and then the net member co-insurance on brands right now is 47.5. As you can see, that pharma piece hit immediately in 2011 and is constant. The other co-insurance percentages are backloaded, and again, you know, it's budget window dressing for the government based on all their budget projections having to be based on a 10-year time frame. So minimize the amount of time that you're providing that extra coverage within the 10-year budget window. So what are the implications of this? As I mentioned earlier, the EGWPs are looking a lot better these days, and RDS plans are looking worse. Predictions across the board from government and private firms are saying the same thing. The Medicare trustees are expecting that roughly probably 8 million people or so right now in the RDS program. They're thinking that number is going to be more like 1 million by 2016. So roughly 7 million member movement between RDS and EGWP plans. Aon just did a survey, and they had 61% of employers changing their strategy in the near future. So this is a 2012 survey, and this was asking them, you know, were you going to change in the next several years? And 61% said yes, they are changing it in some form. And kind of the reverse question, are you expecting to receive the RDS in 2013? That number went down from 66% in 2010 to 40% just last year. So a lot of movement to these EGWP style plans is anticipated. I'll talk a little bit more on the next few slides about the secondary wrap component. But in essence, by having your plan structured as an EGWP with a secondary wrap that layers on the benefit enhancements above and beyond that defined standard Part D benefit from a couple slides ago, you're able to kind of best leverage and maximize the government and pharma discounts. And in fact, CMS actually effectively kind of mandated these wrap products starting 2014, saying that the Part D EGWP portion of the benefit is only to be defined standard or an equivalent benefit. So with all this said, the time to be thinking about this is now. There's a lot of savings out there in virtually all situations that we've seen. There are some financial savings that come along with moving to the structure, especially for your higher cost plans, you know, ones that have a fair amount of brand spend, low generic dispensing rates. The savings are going to be higher. So this goes a little bit into the mechanics of how this is going to work with the wrap product, just to kind of illustrate how that's going to work. So I'm just going to give an example. We're going to say there's a $100 brand name drug. The member would be in the corridor where they would have a coverage gap, and let's say that there's a $20 member copay under their plan historically. So in 2013, the way this would work is that in an RDS plan, you know, there really isn't a coverage gap there. So the cost is $100, the plan pays $80, the member pays $20. It's simple, just like a commercial benefit is usually. Under a pure EGWP, so without a wrap plan, the way it works is they say that any enhanced coverage beyond defined standard applies before the coverage gap discount program or the pharma discount. So the way this works is the plan portion, the 100 minus 20, the $80 is applied first, and then the 50% member or 50% pharma discount is applied, reducing the member's cost sharing from 20 to 10. So under a pure EGWP structure without a wrap, effectively the pharma discount only applies to the member cost sharing. It doesn't apply to what the plan's payment would be. Now, if you set it up with a wrap plan design, the way it would work is it applies the primary coverage and the pharma discount first. And so it's going to apply the 50% pharma discount to the cost of the drug, so it's going to be $50 to pharma. the primary plan, as I said before, there's that little 2.5% that the primary plan or the EGWP is paying, so they pay $2.50. Then the secondary wrap comes in and pays what they really want to pay. The difference to leave the member with a $20 copay at $27.50, and then the member pays $20. So as you can see in this example, the plan is doing substantially better under the EGWP plus wrap than both the RDS or the pure EGWP scenario. And so this is why most plans are moving to an EGWP plus wrap. This had started with some of the bigger PBMs have been doing this all the way going back to 2011. I think now that CMS has kind of effectively mandated you have to have this structure, by otherwise saying that if you're going to have just an EGWP, it can only be a defined standard EGWP. I think you're going to see everybody taking up this EGWP plus wrap type of plan. So what are some of the considerations here? As I mentioned and kind of illustrated with that example, you get the most pharma discounts in that with the EGWP plus wrap scenario, and then therefore by getting higher pharma discounts and by having that be reflected as member cost sharing in CMS formulas, it gets the member to the federal reinsurance quicker as well. So the EGWP plus wrap not only increases your pharma discount, but it increases the amount of federal reinsurance that's paid. As I said, it's becoming much more popular going forward. There are slightly different tests that are required to pass for these plans relative to RDS. Nothing that usually is a deal breaker. The one benefit of the equivalence test relative to the RDS is that there's no minimum employer contribution. So in the RDS program, to qualify, there's kind of a minimum employer contribution they must be making towards coverage. In a EGWP, the member can pay 100% really. Now the employer can't pocket the subsidies, they have to at least share the subsidies, but outside of that, there is no minimum contribution requirement. So it's if anything a little easier to qualify, you know, with an EGWP plan. What you see administratively is that the responsibilities for the employer go down substantially when you move to an EGWP, but the fees go up substantially. So a lot of times you'll see RDS plans that maybe have, it's generally less than $5 PMPM in admin. I've seen them down as low as, you know, $1 PMPM admin. So very low numbers. I think in an EGWP plan and one with a wrap in particular, you usually see anywhere from probably $6 maybe all the way up to $15 PMPM in administrative expenses. There's a lot more work with coordinating with CMS, reporting, and those functions that tend to eat into some of the financial savings that an EGWP plus wrap would otherwise already generate. The PBMs have done a fantastic job with these plans of trying to minimize member disruption by allowing the member to just have one pharmacy card. So you don't have to have two pharmacy cards to present at the counter at the pharmacy and run two different plan designs. It looks seamless to the member. They think they just have the one benefit really, and the magic is done, you know, as far as the adjudication behind the scenes and administering the two separate benefits. Plan design issues, that sort of thing. I think in general you want to think beyond just the financials. You want to think about some of these qualitative things. There are more formulary restrictions and rules in the Part D program relative to the retiree drug subsidy. There's distinctions around Part D versus Part B, so B as in boy versus D as in dog medications, and how you distinguish those and adjudicate those. With an EGWP plus wrap, there is no ability to enroll people that are not eligible for Medicare, so you would have to have a separate plan for those folks still if you offer coverage underneath the age of 65. You know, maybe you lump them into interactive somehow or something like that. There's more rules around utilization management programs, so you can't have, for example, mandatory mail programs that force people to use mail for maintenance medications. There's rules and limits around multi-source brand penalties, so charging the member more if there's a generic available and they still continue to use a brand. Things like those management programs generally are not allowed in Part D, and so there's not as much ability to manage utilization there. Talk a little bit about plan design. There's a few rules. It generally doesn't come much into play, but for some employers there might be some plan design changes that are required. Kind of a two-edged sword here on the income side. High-income enrollees are penalized in Part D, just like Part B as in boy. They pay higher offsetting subsidy amounts to kind of offset the amount the government would otherwise pay in the Part D program. On the flip side, there's low-income subsidies, so members pay less in terms of at the pharmacy counter if they're underneath a certain FPL, and they have premium subsidies as well that benefit low-income members. In general, for your union, government-type employers that offer retiree coverage, I'd say this is usually a win, that there tends to be more people qualifying for low-income subsidies than high-income penalties. But even if you do come out ahead, obviously you have winners and losers, and you want to make sure you communicate that and are very forthright about what's changing, why is it going to change, and what does it mean to both the member and to you as the employer or the retiree plan sponsor. So this grid just shows a little bit of how EGWP revenue works, the various different subsidy cash flow streams, and then what the timing of them is. And I kind of try to group them together depending on the timing. So in the top line you have the direct subsidy and the low-income premium subsidy, the LIPS amount. So the direct subsidy is the amount that's paid for every person that's enrolled in Part D. It's not, that's where the high-income penalty or the low-income premium subsidy are applied. So the high-income people reduce the direct subsidies from the government, and then the low-income people would get an increased subsidy from the government. Those amounts are paid to plans in advance on a monthly basis. So the PBM or the carrier would get the money on the 1st of January for the month of January, and then that would usually be passed back through reduced claims or premium sometime in that month. So those subsidies are received effectively immediately. The federal reinsurance and the LICs, or the low-income cost share subsidies, those amounts are not received by the carrier or the PBM until roughly 9 months after the end of the year. So for 2013, those subsidy values would not be received until 2014. And so in a self-funded situation, the employer is almost always going to be on the hook for that cash flow strain. In a fully insured situation, oftentimes the carrier will kind of take the risk on that, or they'll be passing it back on a monthly basis, and they'll have the cash flow strain. So it kind of depends on the funding mechanism there. I've even seen fully insured situations where the employer is left on the hook for that, and there's a true-up, 18 months after the beginning of the plan year, 24 months. So you do have some cash flow risk there. Excuse me. And then there's the pharma discount, the coverage gap discount program, and then the other cash flow from pharma companies, traditional manufacturer rebates on branded products. Those are usually received on a quarterly basis, but there's always lag time in them. And so you usually see that rebates and the coverage gap discount program aren't necessarily trued up until well after the end of the year either, but there is some quarterly intermediate cash flow streams that are coming in, so you're not on the hook for all of that until September, October, November of the following year. So those are the different subsidy cash flow streams and how they would work. All right. The new guidance that's out there, and this isn't all that new. In fact, this is something that CMS and HHS kind of floated out there in late 2011, and then they finally codified it in April 2012. It's just it was highly misinterpreted by the industry, I think, based on it being very ambiguous and not clear in how it was written. But in effect, what the provision said is that if you have other non-Medicare coverage, or if you have enhanced coverage, it's going to be treated like non-Medicare coverage outside of Part D. And so most carriers, consultants, etc., I think interpreted that to mean that you didn't need the wrap anymore, that even if you offered enhanced benefits through an EGWP, they would just be treated like non-Medicare benefits, and you would get the subsidy early on. So going back to my example, sliding back a few slides here, in this case, what the early interpretation was is that, in the pure EGWP scenario, that $50 pharma discount would apply first. Primary would be 30 and member would be 20, in which case, why would you ever want to go through the concern of having a wrap and all that, hassle? Well, really, CMS came out about 6 months later in October and clarified verbally, and then in January of 2013 finally put it in writing and really clarified their position that their intent was that anything that's beyond Part D basic coverage or a defined standard coverage is to be covered through a commercial wrap product that would be subject to state regulations and commercial ERISA rules, not necessarily Part D rules that exempt you from all the state laws. So this led a lot of carriers to be scrambling to get these wrap products back in place and get the necessary state filings done if they were going to be offered on a fully insured basis, and that sort of thing. So that on the next slide, the consequences, all the EGWP benefits are going to be basic starting in 2014, and the wrap product is going to be needed. It does seem like the wrap products are exempt from a lot of the ACA provisions, like the health insurer tax, like the MLR requirements. It seemed to kind of lump these wrap products together with Medicare supplement products that are treated, are exempted from a lot of the ACA type provisions. It's not 100% crystal clear, and so not being an attorney, I'm not going to declare it definitive, but that's the interpretation that I have seen so far of it. So, who are good candidates to move to these EGWP plus wrap plans? From my perspective, I think it's worth looking at for any employers, unless you are only offering retiree coverage to maybe 5 retirees or a very small population. If you have any size, it oftentimes makes a lot of sense. So for government organizations, as discussed earlier, there's that retiree liability rule that makes it even more attractive for them. For plans that have higher drug spend, because the subsidy and the pharma discount can be higher, those help more for those plans, and they can tend to see more relief. And then group size, as I mentioned, a lot of PBMs and carriers are not going to be willing to customize plan designs or even offer these plus wrap products if you're a retiree that only has 5 retirees. They're going to want some size to come along with the work and administration of administering a separate plan design for the employer. What's the future? As I said, with the CMS guidance, that really changed things a ton. I think you're going to see, following along the glide path that the CBO or the Medicare trustees had laid out, I think you're going to see RDS plans really go by the wayside, and this become the primary way to provide retiree coverage. It's probably going to be either employers exiting altogether, or more commonly those that want to stick around and still provide coverage moving to these EGWP plus wrap plans. With the pharma discount, as I mentioned, originally the pharmaceutical companies are only signed on for this through 2020. Now it'd be horribly unpopular if they said we're not going to pay for this after 2020. I don't know that they could politically do that, but that's all they're signing on for. And another nuance here is that I don't think the pharmaceutical companies had any idea that there was going to be this kind of movement to employer plans based on this. They had no idea that there was going to be this kind of shift from RDS to EGWPS, and that they would really be funding employers in a lot of cases through this EGWP coverage gap discount program. I think there's some concern there and potentially some pushback going on to say this isn't what we intended at all. We wanted to help individuals, not necessarily reduce employers' retiree liabilities. One concern with EGWPS is that the direct subsidy that we talked about throughout this, and some of the other subsidies as well, are all linked directly to the individual program. And the individual program in Part D has, as I talked earlier about, incredibly higher levels of competition and things like preferred networks, very, very lean formularies, and just competitive issues like that that really drive down those subsidies because it's a competitive marketplace. In the employer space, while it's competitive, it's not nearly that competitive, and so you're seeing these subsidies go down from year to year while employer trends are still somewhat positive in most cases. And so the subsidy values aren't going up as quickly, and that's hindering potentially some of the movement you'll see. Another thing to keep your eye on for 2014, the risk model, so the risk adjustment program that impacts Part D and dictates how much are going to be paid for any given member based on their health status, that applies to employers and individual plans. And one of the changes for 2014 is it appears like they reweighted the risk adjustment methodology to effectively reduce non-low-income risk scores by about 10% and increase low-income risk scores by about 10%. So this is another thing that's going to drive employer subsidies potentially down for EGWPS. And then finally, sequestration. There's a 2% adjustment that's applying to the Part D direct subsidy and the pharmaceutical discount program, and that would apply both to individual plans and employer plans. So in general, there's some challenges out there, you know, the things I'm laying out on this slide. With that said, in general, we think this is still going to be financially advantageous for most employers to think about and at least run the numbers and see how things look, because there's a lot of money on the table out there that is too much to pass up in a lot of situations. So just some quick conclusions before we move into the question and answer. Healthcare reform, big impact on the relative attractiveness of the different employer options, that even though it didn't necessarily reshape the whole Part D program, it reshook the equation for the relative value between RDS and EGWP plans, and EGWP plans with wraps appear to be the play for the future. There's a lot going on in the industry, and the fact that a lot of plan sponsors are looking to cut costs already, this is a great lever for them to potentially tap into. As we talked about, there are some complexities, you know, headwinds, things like that, that make it not a given in every situation, but most cases they're not deal breakers that most employers say, yeah, it's probably worth these few hassles for the kind of money I might be able to save and then be able to maybe share with my retirees through other ways. From an implementation perspective, you know, once you're in an EGWP, it's fairly status quo from year to year. There's not a lot of change for the members, but that transition year from RDS to EGWP can be complicated. It can require a lot of rollout time, and in general, communication is just really important. So I wouldn't see it as something that should deter people from going into the program, but it's something to be aware of and be ahead of such that you're ready, you know what questions to anticipate, and how to position it with your retirees such that they see it as a benefit too. So with that, I am going to just a quick caveat slide, and then I will open it up for question and answer.
Okay, well, thanks very much, Troy. You've given us a lot to digest here, and we do have a couple of questions. Can you explain the drop in the direct subsidy in 2013 due to national bids coming in lower and the risk scores dropping? And along with that, what do you predict will happen to the direct subsidy in 2014?
Sure. So the change in the well, I'll start with the risk score piece. There wasn't a substantial change for 2013 for the risk scores. Those should be fairly consistent from 2012 to 2013 in Part D. The big change will be in 2014. And that is not necessarily going to impact the national benchmark that substantially, because they reweight the risk scores to have kind of a net revenue neutral impact. So the fact that non-low income went up a bunch and low income went down, it will usually net itself out, and your national average should hold roughly similar, all else equal. Now what you will see a fairly substantial amount of change in is the low income regional benchmarks, and those are kind of separate, but those do dictate what low income premium subsidies are paid, and I would expect those to go down substantially year over year heading into 2014 based on the low income risk scores going up. Kind of the other question you posed, which was on why did the national average change into 2013, and then what are the expectations for other reasons going into 2014. 2013 there was a huge change with United Healthcare, and if you're familiar with the Part D market space, it's very concentrated amongst basically three carriers, Humana, United, and CVS. And so when any one of those three makes a substantial move, that can have big ramifications on the national average. And United had been offering plans that were in the $35 to $45 range from a premium perspective, and they revamped their entire product offering and came out with a very lean network, a very lean formulary plan design where their premium is now $15. So that's what I'm talking about, where I say individual market players and strategies have a huge impact on the employer market. That change by United was the major driver that caused the direct subsidy to go down $5 from 2012 to 2013, and that's a huge amount, by far the biggest change since the second year of the program. So that was very unexpected, and it was largely driven by one carrier's strategy. So that's where in the future there's always that whim where competitive strategies and that sort of thing are going to impact the market. And unfortunately, if you're a plan sponsor out there, an employer, what United's doing in the individual market doesn't mean squat for you in terms of what your drug trend is. So your drug trend might still be 3-4% a year, and you're thinking, I'm doing pretty good. 3-4% a year is a lot better than historical averages. But you're seeing your subsidy funding drop by $5 because of United's individual market strategy. So it's, I guess what I would say, an unfortunate consequence for employers in the market, but one that I don't see changing because it works in the government's favor and helps keep costs down. The last part of that question was what to expect going into 2014. That process is just starting right now, where employers are submitting their bids in about the next 2 months. The rules of the game have just been kind of established. As a very preliminary sense, we don't see things changing a ton relative to last year. So I wouldn't project major movement up or down in the direct subsidy. I think you have offsetting forces of still quite a bit of generic, brands going generic. You have the competitive pressure still, but on the flip side, you have specialty trends at 20 to 25% a year. You have other costs like the health insurer fee that's going to add 1 or 2% to bids. There's sequestration that plans are going to bid a little higher as a result of that. So there's kind of some offsetting forces that I wouldn't see it moving substantially in either direction.
Okay, we've got a couple more questions here. The first is, how will closing the donut hole help or hurt the EGWP Wrap employer retiree savings?
Yeah, so that's the big driver of the savings on the Part D side or the EGWP side, that you're getting a lot higher subsidies from the pharmaceutical companies or from the government because the donut hole is being closed. So kind of the EGWP value equation is going up based on that. And on the other side, the RDS, if you're a taxable entity, you're paying more tax, and the value on that is going down. So that's where the movement to EGWPs is anticipated.
Okay, and we have one more. This attendee says, I thought I heard Troy say that sequestration affected both direct subsidy and the pharma discount payments. Is that the case?
It is the case. I was a little surprised by it as well. I don't think that the final guidance is out there yet on how this is going to be potentially trued up at the end of the year. But at this point, and we've confirmed it with a number of our clients, the amount that they got paid from the government as of April 1st for both the direct subsidy and the coverage gap discount program was reduced by 2%.
Okay. And that is all the questions we have right now. So thank you, Troy, and thanks as well to Transamerica Affinity for arranging for Troy to lead this afternoon's webinar. Just a reminder that you will be receiving a link to the recording so that you can go over it again. We hope to see many of you at our upcoming Atlanta conference, April 28th through May 1. If you can't make that one, I hope you'll consider joining us in Chicago in June. Again, thanks for being part of today's session, and we hope to have you at another webinar. Bye-bye.